and to be published in top-ranking impact factor journals. So if you are interested, Alhambra 6 to 8, level -2. Thank you very much.
Mr. Chairman and gentlemen, it is really a pleasure to have this international congress. In the first time, I feel that our national congress became this international level. We have to thank the organizing committee and all the board of the society for these efforts that really impressive to all of us. The title of my talk today is Hepatitis C and Renal Transplantation. This is the virus. Actually, it is one of the members of the flavivirus, single-stranded RNA. It circulates either freely or in lipoprotein-associated envelope. And this is the structure of the virus. It is RNA genome surrounded by protein core and the lipid envelope, 10,000 nucleotide sequence, open frame ring with 5 conserved region. That is the one at the extreme end. The open ring frame can be cleavaged into a core protein, 2 envelope, a core protein, 2 envelope proteins, and the 5 non-structural proteins. And this classification is helpful because we shall see that the detection of antibodies with different tests, that is the 1, 2, 3, detected different parts of this virus. There is genotypes, and in one of the studies that had been done at the health department in Cairo University, they found that 90% of the studied group is genotype 4. The other genotypes constituted about 10% or even less. The virus, once invaded the victim, it resides and starts to multiply either in the liver cells mainly, lymphoid tissue, whatever they are, spleen, lymph nodes, and some studies show that it can reside in the renal tubules. How we diagnose the HCV? We have different tests for the antibodies. We have PCR quantitative, that is the overload number, and maybe genotyping tests. As you can see, the ELISA 1 can check the one of non-structural proteins. ELISA 2, they add a sort of envelope proteins plus the non-structural. REBA added the NS5, and at last ELISA 3 added C20 and C100. Quantitative test, that is the viral load test, is important in deciding the treatment and follow-up of treatment. The prevalence of hepatitis C, as you can see in this map, that the main incidence is coming here in North Africa, and I don't know the exact figure for prevalence in Egypt, but different statements is may reaching up to 30% of the population and more in the renal population. What is the source of infection? In the same study done at the public health department, from the past history of 40 patients, they found that the highest incidence of the past infection is due to dental process, Next to it, it is bilharziosis and its treatment, the use of non-sterile injection, and at last operation. That's why probably these sources of infection are important in whenever we want to do a sort of avoidance of this source of infection. The prevalence of HCV infection in patients on the waiting list, as you can see here, from 1990 up to 2002, the marked drop in the incidence of antibody testing in the patient on the waiting list for transplantation. The first important issue, is it necessary to treat patients on the waiting list or not? Actually, absolutely yes. Why? The treatment is effective, better outcome after transplantation. Tolerance and side effects are minimal, and the high risk after transplantation if the patient is still PCR positive. And if decided to treat, which type of treatment? Interferon alone is the best. Which type of interferon? Shall we use the standard alpha interferon or the pegylated ones? In fact, the standard alpha interferon is effective and the side effects are known. Its dose is known and can easily adjust it. On the other hand, the optimal dose of pegylated alpha interferon is difficult to adjust due to its slow clearance than the ordinary or standard one. And this slide shows the pharmacodynamics of interferon, alpha interferon, in the dialysis patients and in the normal population. The blue columns are the normal, the dialysis patient, and the gray one are the normal patient. As you can see, the half-life is nearly double in the dialysis patient compared to normal population. Similarly, another study showed that the delayed clearance of interferon in the dialysis patient. To whom we shall treat? Any HCV positive, RNA positive patient referred for kidney transplantation. Liver biopsy is mandatory. After genotyping must be done and the viral load must be done, but be sure, never, or be aware, never to start transplantation if your candidate is under treatment. The efficiency of interferon is clear. In whom? In patient with mild liver disease, not severe liver injury. Patient with low titer of RNA, short time of infection, and we have to consider the different pharmacodynamics of the interferon. And what is the outcome? So long as we shall treat these patients before on the waiting list, before transplantation, we want to know how it is beneficial to give this treatment. In fact, less HCV-related glomerulonephritis after transplantation had been published in AGT in 2003. Less severe histological liver lesion after transplantation. And this is more important, it has been published that in cases of HCV RNA was negative at the time of transplantation, there is no relapse following transplantation, even when the immunosuppression was intense. If we treat our patient and we're proceeding to transplant him, what about the donor? The main choice, shall we use is seropositive donor or seronegative donor? In a seropositive recipient, is there any difference? If the donor is RNA negative, no risk for the recipient whatsoever. But if the donor RNA positive, there is two choices. If you use recipient seropositive and the donor is seropositive, no problem, proceed. But if you use a seropositive and seronegative recipient, 50% will develop hepatitis-related hepatopathy, and this is a great ethical problem. That's why the message is use positive to positive and don't use positive to negative whatsoever. And this study that had been published showed the difference between giving a positive to positive or negative to positive. We have 158 HSV positive recipients, and the donor was donor positive, recipient positive, donor negative, and recipient positive. Does it differ? They found that the graft survival, insignificant difference between the both groups. What about the patient survival? Similarly, there is minor difference between the two groups. And what about the liver function? Insignificant difference between the two groups. And this another study, 10 years experience with transplantation of HSV positive recipients, mean negative or positive. And they found that the graft survival in the positive group was 74, and the negative group 79, insignificant difference. Patient survival are nearly the same, liver functions are nearly the same. I believe from this study it is clear that we can use a positive, it is no need to search for a negative donor to a positive recipient. If the patient proceeded and transplantation had done, what is the post-transplant evolution of this patient? We shall discuss what about the antibodies. Is there any change? What about the graft complication? What is the hepatic chronic disease progression, survival of the graft of the patient, the incidence of infection and new onset diabetes in this patient, and at last, which is most important, what is the impact and effect of the immunosuppression, and there is any special recommendation for this group. Regarding the antibodies, as you can see, here a comparison between the antibodies in hemodialysis, peritoneal dialysis, and transplant, the highest incidence in the hemodialysis group. And here it shows that transplant recipient, the incidence of antibodies in many studies is variable, different from 17% up to 45%. And in this study, they found that in new transplant is the incidence decreasing, the same pattern as we saw before. It dropped from 30% up to 10% in HSV positive recipients. And what about after infection? Is there any change in the antibody? This study showed the comparison between liver enzymes and RNA quantitatively. It is definitely higher liver enzymes, a higher viral load after transplantation. And this is something expected due to the immunosuppression, and at this point we shall discuss which drug and which combination can minimize this increase in the viral load. What about the patient survival? Actually, 5-year survival was not affected in most studies. This is for the patient. Longer-term survival was lower in all reports in positive patients, and in our study showed the better survival with transplant compared to dialysis in studies published at 97. And this study showed that up to 5 years, there was no difference in the survival, and the deterioration starts after 5, reaching the maximum 20 years. This study showed the similar results, but the separation was earlier than 5 years. In another study, they tried to combine between the viral status, the PCR, and the liver enzymes. And it is they found that the higher the liver the enzymes, the worst is the graft survival. As you can see, if they have PCR positive and abnormal liver enzymes, that is one, has the lowest survival. Those PCR positive and normal and PCR abnormal are nearly the same. This means it is not the muscle of the viral load, but it is the liver function. If you combine them, they are more protective, and can give us more impression about the patient survival. What about the graft survival? It is affected especially in blacks. Higher rejection episodes had been reported, but in not all studies. Mesangial-proliferative with without cryo had been described in the renal allografts. What about the graft survival? This study joined the PCR with the liver enzymes. If both abnormal, the 9-year survival is the best. If you have positive PCR or normal liver enzymes, is less, but if you have PCR positive with abnormal liver enzymes, 50% survival after 9 years. The glomerular lesion that had been described in association with infection in renal transplant patients, it is membranoproliferative glomerulonephritis with or without cryo, membranous nephropathy, fibrillary GN, thrombotic microangiopathy, and transplant glomerulopathy. What about the hepatic post-transplant disease? In fact, the pathogenesis of all lesion associated with HCV, it is a combined of cytopathic effect and immune-mediated effect. The same for the liver. In the early infection, the viral load is the predominant, and it is the cytopathic lesion is the main player. With the progress of disease, the viral load may be less, but the immunological response may become the main player in hepatic angina. The follow-up of the liver disease after renal transplantation, if we follow the liver enzymes and the PCR, have the same pattern as we found in the renal side. Both the PCR increase after transplantation, and the liver enzymes increase also. What are the risk factors for worsening deterioration of the liver function after transplantation? The most important is the persistence of hepatitis B virus. 26% of these patients develop cirrhosis within 1 year. The type of the immunosuppression. Better with cyclosporin than with AZA or monoclonal antibodies. Histological activity more severe with AZA. Fibrosing cholestatic hepatitis common with AZA. Time antibiotic of pre-transplant hepatitis, and that's why important to screen this patient post-operatively. And this is the liver profile in patient dialysis compared to transplantation. They are compared persistent elevation, intermediate elevation to the normal. As you can see, in the renal transplant patient, the persistent and the intermediate elevation is more common. Regarding the incidence of chronic hepatic disease in this patient, variable incidence, 60, 75, 34, or different authors, different percentage. Increase in the risk of post-hepatic disease in those who are seropositive pre-transplant. Regarding the histology,